Everyone, please join me to welcome our wonderful speakers, Zahra Shakeri and Swetaprovo Chaudhuri, on today's session on artificial intelligence and data. And welcome everyone for thank you everyone for registering for our webinar and joining our discussion today. So we actually want to start with acknowledging that this land on which the University of Toronto operates for thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississauga people of the Credit. Today, the meeting place is still the home to many Indigenous people from across the Turtle Island, and we are grateful to have opportunity to work on this land. So since 2023, Institute of Health Emergency and Pandemic has provided over $1 million to research teams at the University of Toronto to support collaborative interdisciplinary research projects that tackle challenges in pandemic preparedness, responses, and recovery. The purpose for the seminar series today is to highlight the interdisciplinary teams and their work. And I'm Dr. Das, welcoming you everyone to the discussion today. I'm a postdoctoral fellow funded by the Institute of Health Emergency and Pandemics, housed in the Department of Computer Science at the University of Toronto. And today we have Dr. Zahra Shakeri and Dr. Swetaprovo Chaudhuri discussing about the research with us. Before we get started with our discussion, I want to share, take care of some housekeeping stuff before we get started with that. So if you need closed captions, there is a caption button at the bottom of your screen that you can click to turn on or off. They are AI generated, so they may not be the best, but they're available if you want. And if you have any questions for the presenters today, there is a Q&A feature at the bottom. Feel free to enter the questions you have at any time, and we'll get to that after both presentations have been done. So we will have this recorded and the presentation slides available about a week after the webinar. We'll send those out everywhere to everybody who has registered and through listserv and social media channels. So we'll get started with Dr. Zahra Shakeri's presentation today. So Dr. Zahra Shakeri is an assistant professor of the Health Informatics and Information Visualization and the director of the Hive Lab at the Institute of Health Policy Management and Evaluation at the Dalla School of Public Health. She has received her PhD in computer science from the University of Calgary and completed a postdoctoral fellowship at Gallenberg Lab in the Department of Biomedical Informatics at Harvard Medical School. Dr. Shakeri's research interests are focused on health informatics, health data science, information visualization, precision public health, digital health, social media data analysis, natural language processing, NLP for short, and artificial intelligence or AI. Her work aims to leverage data and technology to improve health outcomes and patient care, with a particular emphasis on developing innovative approaches for analyzing and visualizing health data using NLP and AI techniques. Dr. Shakeri, welcome to our discussion today.
Thank you so much. I'll just start sharing my screen. Could you please confirm if you can see the slides?
We can see the slides.
Awesome. Thank you so much for the introduction, and thanks a lot for the opportunity to present the work that we started 3 years ago, almost 3 years ago, and we received some funding support from few resources, including the Institute of Health Emergencies and Pandemics. So this is an amazing opportunity to be able to present the progress on the project. So today, I'm going to talk about listening, not listening to individual complaints one by one, but listening at a scale that was previously impossible. And we can say still it might not sound very possible, but previously it was almost impossible to do that. So I'm going to share how in this project we're using AI to transform massive patient stories into a blueprint for more resilient, equitable healthcare system in Ontario, and hopefully in future stages of the project to expand it to other provinces in our country. So we all know the numbers that define the pandemic. We know about case counts, infection rates, ICU capacities. But when we were counting beds, we were missing something equally vital, the voices of the people in them. So between 2017 and 2021, over 120,000 patients in Ontario left open text comments about the quality of the care they received. And buried in that unstructured data was a silent crisis of access, equity, and trust that spreadsheets could not capture. And today, I want to show you how AI can help us to finally listen to them and not only just rely on historical data or the data that was collected from 2017 to 2021, how we can use AI to expand the scale and the depth and the scope of the data that we have in this context. So we all know that trust is the currency of public health, but recent data shows a dramatic decline in Canadian confidence. For example, in 2021, 77% of Canadians felt confident the healthcare system would be there when they needed the system, but 2023, that number had dropped to 67%. Why? The answer is not just in wait times. It's in the experience of care that our patients are receiving. So we know the general visits declined during the pandemic, but I want to draw your attention to the bottom half of this screen because it reflects a much more serious problem. In those early months, preventive care did not simply decrease, it almost disappeared. For example, mammograms dropped by 97% and pap tests dropped by 88%. We describe this as a tsunami because these are not routine delays. These actually represent thousands of misdiagnoses that quietly fell through the cracks during the pandemic time. And that 41% drop in emergency department visits did not mean people were not having heart attacks. It meant they were dying at home or coming in too late to be saved. And looking at this chart, the cremation records in Ontario show that the province saw about a 13% rise in deaths during the pandemic. And these excess deaths came from both COVID and non-COVID cases. And from, in early waves, yes, we can say that we had lots of late diagnosis for COVID. But in later waves, higher non-COVID deaths appeared to be related to delayed care for conditions like cancer, heart disease, as well as other indirect effects of the pandemic, including a huge increase in opioid-related deaths. And early data during the time showed that largest increase in opioid deaths was among people aged 25 to 44. So these excess deaths were largely because of the delayed access to care for conditions like critical conditions like heart diseases and diabetes. CTV News during the time also reported that emergency physicians were seeing a wave of patients coming back with far more severe outcomes, including heart failure with fluid in the lungs and advanced strokes because they had stayed away from the emergency department for too long. So, and these are just some basic stats, but we often talk about the equity gap as a theoretical concept, but the data from this period makes it undeniably concrete. We can see some surprising numbers. Like, look at, for example, if you just look at the digital divide, we can see that immigrants with language barriers accessed virtual care at significantly lower rates than the general population, not because they didn't need care, because the digital front door was blocked by language and literacy barriers that we had. Or just look at the disproportionate impact among different racialized communities. So it isn't just about readmission. When we talk about like poor quality of care, it's about survival. And the Statistic Canada reported that for Black Ontarians, for example, in low-income settings, the COVID-19 mortality rate was 3.5 times higher than for the non-racialized population. And in Toronto, we had 79% of COVID hospitalizations came from racialized communities that we will see in like next slides. So, and I just want you to look at the striking overlap between these two maps. On the left, we see where Toronto's Black communities live, and on the right, the COVID-19 hotspots. So it becomes visually very clear and undeniable that the virus did not hit everyone equally, but it was kind of targeted specific, it targeted specific neighborhoods that were already structurally vulnerable. And as I mentioned earlier, we had in Toronto, we had 97% of COVID hospitalizations came from racialized communications. And we had, during the time, we saw 19% higher readmission rate from neighborhoods that were economically disadvantaged. So online reviews, I mean, all of these statistics confirm that vulnerable patients are falling through the cracks in our healthcare system, but they don't give those patients a voice. And we, in this project and in our the research that we have been doing around this topic, we believe that online reviews can fill that silence, and if they can help us to provide a critical window into the post-discharge reality that standardized metrics simply cannot capture. And we can see that patients are now treating healthcare choices just like any other major life decisions. We've gone from a small fraction checking reviews in 2013 to a massive 70% majority today, which means reputation is often established before they even walk through the door. And patients are checking those review systems, or they are kind of trusting the review systems, or at least involving those systems or the data coming from those systems into their decision making. And it also turns out hospital leadership actually agrees that the experience needs work. Even though they trust the medicine, they admit that the key to better overall quality is not more clinical precision, but better patient engagement. And patient engagement also plays a crucial role in the context. So, but here is exactly where the system breaks down. We go through the trouble of asking patients for the inputs, but when we have the results, and when we have the request or complaints or feedback from the patient, which are like the core input to like an impactful change, we usually ignore them, and we are collecting the dots, but we are refusing to actually connect them to each other to end up with a meaningful insight or a meaningful input to our healthcare system. And just imagine spending 68.5 million on a roadmap, which was actually spent by Ontario government to collect this data, and then immediately throwing it in a drawer. This is effectively what happened here. I mean, with the data that was collected from 2017 to 2021, it's a massive amount of money went into collecting and generating this feedback, but the detailed comments and even the exact financial details are still hidden and not published for the public view. So in response to this growing concern and all growing concerns about hospital conditions, the Toronto Star and investigative journalism brew at Dalla School of Public Health. They fought for a lengthy freedom of information battle to access 6 years of survey data from 57 hospitals and health networks. And in total, the number of survey or data points that we had in this survey was 120,000 comments or feedback from patients. From some institution, this valuable feedback was not just ignored, it was effectively thrown away. 7 hospitals in the system did not even retain the full comments, which means those specific patient stories and insights are gone forever. And you can't fix a problem if you delete the diagnosis, and we all know that. So, and this quote really hits home because it shows the human side of that wasted data. You have a mother who genuinely believed her feedback would help the hospital learn and make better, only to come back and see that absolutely nothing had changed. So it's hard to keep trusting a system that asks for your opinion and then refuses to act on the data or on the opinion you have provided. So since the official data is locked away, we thought that crowdsourcing becomes our only real-time radar for the truth. It helps us to bypass the administrative silence and immediately detect these massive disparities like the wild variations in surgery wait times that the system is failing to fix, or disparities that we have related to like other contexts. For example, patients who don't speak English or French are 30% more likely to experience a harmful event during their hospital stay compared with patients who speak one of those languages. So we thought that using AI and crowdsourcing, we can at least take some steps to fix this problem. We use AI to spot the broader trends without compromising anyone's privacy, and I will shortly show you that how our system works. It allows us to turn those scattered stories into some actionable data without ever needing to expose a patient's identity, for example. So we started with a very simple case study in with the support that we received from the Institute of Health Emergencies and Pandemics, and also Transform Heart Failure at the University of Toronto. We started looking at social determinants of health in Ontario hospital feedback with a specific case study related to heart failure patients. And as the outcome, we developed a system that would help heart failure patients, stakeholders, or the public locate a hospital of their interest and see the trends of comments received from patients during the timeline that we have for these basic data sets, because we started with those 120K comments that we received from Toronto Star and IJB, and I will show you shortly how we are hoping to expand the scope of that project, that data set. And in these SDOH platforms, at least stakeholders, decision makers, the public can look at the trends, and based on the AI pipeline that we implemented, and I will explain shortly, we can classify comments to specific predefined categories of SDOH, which can help a lot with the awareness, at least in the context, for decision makers and stakeholders. And to teach our system to understand complex patient stories, we implemented an experiment with the core data set that we received from Toronto Star and IJB, those 120,000 narratives, to find the best training method. So we found that relying only on human experts was not enough. So we decided to split the data to different portions. We had human labeled portion that was used to fine tune our AI models, and we used the latest and the most accurate version of GPT model I mean, based on the claims that are available out there, this should be the most accurate model. But again, we understand that when you have larger scale data and you have very limited number of labeled data points, there is always a chance that model might hallucinate, or it might not be the best choice, because we go with zero-shot learning in this case. We don't have a ground truth for all the 120,000 data points. So for this reason, we have started an iterative process. As you see here, we started with 5,000 of manually labeled data, and research in the field also shows that sometimes having a small model fine-tuned with a high-quality data can outperform some of the frontier larger scale models like GPT, and this is how we are doing. In the dashboard that I just demoed, we have the very first version of the model deployed, but we are hoping to involve human in the loop by adding a reinforcement learning component to the pipeline. And hopefully in the future, we will have more accurate classification for SDOH problem in this context. And this figure also presents a heat map of visible minority percentages across Toronto's 6 hospital regions. And the bar charts also showing patient review sentiment. The heat map color gradient here represents visible minority populations from 0% to 90%. And bar charts also show positive, negative, and neutral sentiments for COVID and non-COVID related reviews. And we can see that regions 1 to 4 contain more than 40% visible minority populations, and regions 5 to 6 show less than 40%. So we use this map to kind of justify the results of our natural language processing pipeline to see how we can map some of the findings of our study to some more context sensitive concepts in this problem. So, and the next part of the solution, or the next component of the solution that we have been working on in this project is the crowdsourcing platform that we have been implementing since we got some initial results from those 120K feedback. So this is actually the main solution that we are proposing, the Canada Hospital Review Network. And this is the very first real-time intelligent Canadian system that would map would map the feedback that we receive from the patients to some actionable decisions. So this system is built on the simple philosophy that better hospitals start with your story. So it starts with a patient first intake that takes usually less than 3 minutes, and then our system in the backend uses an AI to instantly transform those personal narratives into visual evidence. And this would allow us to finally operationalize empathy and turning individual stories that are usually ignored into conversation-ready data that hospital leaders can act on immediately. And here is the landing page of the system that I just explained. And here we have a very quick demo of this intelligence system, crowdsourcing intelligence system. The system is up now, and I should probably, it might be good to share the URL also with the audience here. So here we start with the landing page where we collect the stories, but the real power is actually in the AI component, the chatbot, instead of, yes. Yes, it's working. So the chatbot, instead of spreadsheets, we can just ask plain English questions, like asking for a list of top-rated hospitals in Ontario. Currently, the data that we have is limited to those 120,000 stories feedback that was collected over 5, 6, 7 years. But we are hoping to launch and launch the crowdsourcing component very soon, so we'll have more data from the public. So when we ask about wait time, for example, it goes much deeper. I mean, it's not just about numbers. It would analyze the sentiments behind the delays and pulls up specific relevant um, text snippets to prove it. And we also have visualizations for specific hospitals, all the 57 hospitals included in our system. We have the data stratified based on hospital units, based on the location, based on the context, or based on the like type of the hospital. And we can also click on, I mean, for now we have only data coming from Ontario, but in the future, if we add data coming from other hospitals, we're just clicking on the province. You should be able to see the hospitals included in our system coming from that province. And for each single hospital, you can see the dashboard of the hospital. You can talk with our AI agent to learn more about different aspects of the hospital, and you can ask direct, simple questions about your need and see what would be the best hospital in your neighborhood, for example, for that specific need. And we also have at the very end of our landing page, we have also a sub page that would ask for like collaborations with hospitals. We ask them to claim their own dashboards. So in this way, they can apply for an access, and after they have access to, I mean, they actually play the admin role. After they have access to their own dashboard, this is exactly the time that we expect that the whole pipeline of solution deployment starts. They can see, this is a time that we can actually do the awareness and we can start the decision-making process. So, and here is the chatbot that I just described, and here is the process or the AI architecture behind this chatbot. The brain, I mean, this is actually the brain behind the platform. So at the center, you can see that we have the Minds database agent acting as a controller. And basically, this controller prevents the system from just guessing answers. So instead of just guessing, it pulls verified facts from our knowledge bases on the right and uses real data tools on the left of the pipeline before framing a response with the LLMs at the top. So this would kind of help us to make sure that when a patient chats with the interface you see here, or you saw in the demo, the system is grounded in our actual hospital protocols rather than just hallucinating information or grabbing information from other resources that are used to train the LLMs that we use for this project. And also wanted to quickly show you the actual science backing this up. We started the implementation of the tool and doing the research on the project at the same time. And the results of processing those 120,000 patient stories to confirm the value of this data are published in the first paper. And we also identified a major risk, which is AI bias. That's why we developed the second algorithm published in the second manuscript called Fair Care NLP. It's our specific framework to show that algorithm doesn't just pick up, to make sure that the algorithm just doesn't just pick up the loudest voices, but it actually listens to everyone fairly, which is a very concerning issue in crowdsourcing platforms. Just make sure that the reviews that you receive are fair and they're not biased. So there is nothing more valuable to the healthcare system today than the voice of the patients, as said by Dr. Adamson, an associate professor of social work at the University of Toronto. So here in this project also, we try to fix this. The hospitals when they were asked that why the patient's data are ignored, the hospital's defense was that they couldn't verify a single anonymous comment, and they are right. But our AI core changes all of these rules by changing the unit of analysis. We stop trying to investigate who said it and start investigating. I mean, we don't care who said like the comments. We actually start investigating what they are collectively saying. If one person complains anonymously, it's valuable. But when our agent or AI agents detect that, I mean, one comment is anonymously is valuable, should be considered. But when our AI agents can detect that, for example, 500 people in the same ward are flagging the exact same issue, that like anonymity doesn't matter anymore, and the pattern becomes the proof here. And we finally move the system from asking who is to blame to asking what is actually broken and taking some real world actions. So I would conclude here, and thank you so much again for the opportunity to present our work.
Thank you, Dr. Shakeri, for sharing your really insightful and wonderful works with us. Just as a reminder for the participants, if you have any questions for Dr. Shakeri, just note those down in the Q&A part of the webinar, and we'll get to those after the second presentation. So at this point, I will welcome Dr. Swetaprovo Chaudhuri to present his work. Dr. Swetaprovo Chaudhuri is a professor at the Institute for Aerospace Studies. He works in turbulent, reacting, and multi-phase flows and has contributed to the understanding of turbulent flame stabilization, propagation, and structure, as well as infectious aerosol dispersion using theory, computations, and experiments. He earned his PhD from the University of Connecticut. Subsequently, he worked at Princeton University as research staff and then as a faculty member at the Indian Institute of Science. Professor Chaudhuri has authored and co-authored over 100 articles in journals, conferences, and books, and has been honored by several organizations. He is an elected associated fellow of the American Institute of Aeronautics and Astronautics and is a member of its propellants and combustion, the technical committee. He also served as a member of the COVID-19 modeling consensus table. Welcome, Dr. Chaudhuri.
Thank you very much, Dipto. Let me share my presentation. I mean, hearing Dipto giving this introduction, if you think, what is a guy from aerospace engineering doing here? Don't worry, you are not alone. I was also thinking about that. Anyways, actually turns out that what we do in terms of like propulsion and reacting flows, the fluid mechanics and the things we use to describe turbulent flows, the probability distributions can be useful in understanding certain features of disease spread as well. Anyways, first of all, I'd like to thank my co-authors, Arnab Mukherjee, my PhD student at Institute for Aerospace Studies, who has done all the work. And I'm very grateful for the very productive collaboration with Professor Sharmishta Mishra at the Department of Medicine and Professor Kumar Murthy at the Department of Mathematics. And their collaboration has really enriched this work and has opened quite a few new insights, and I'm really thankful to them. Now, we started this work on analyzing distributions for COVID-19 infections in schools during the COVID-19 outbreak as well, and where I met Professor Mishra and Professor Murthy. And I must thank the Institute for Health Emergency and Pandemics for enabling us to continue that collaboration beyond COVID-19, and which has led to some insights on how on the disease distributions, on the infection distributions in shelters. So why do we care about distributions? First of all, I mean, of course, we know that there are not the reproduction number is the most useful metric or most used metric in a pandemic evolution. and to describe an epidemic outbreak. What it means is essentially the average number of infections that is caused by an infected individual in a susceptible population. Now, if it is an average, any average must evolve from a distribution. And for some distributions, an average is a good measure. But in case of distributions like those involved in airborne disease outbreaks, like, for example, in the SARS, where this distribution was obtained by Lloyd Smith et al. In this pioneering paper, you see that such a distribution has a very long tail. And in this kind of long tail distributions, the average will not be meaningful to describe all the features of the outbreak. Because as you see here, that yes, there is the highest probability is that a very small number of infections, very small number of generation of secondary cases, but there is a small but finite probability of generating very large number of secondary cases. And this leads to this evolves from basically what we know as a super spreading event. Now, what the drawback of one metric like the reproduction number or the total infection count is that it obscures the strong heterogeneity that is embedded in this kind of distributions. And it obscures critical features of the outbreak dynamics, such as the super spreading events. So what is the remedy? The remedy is that can we somehow try to model the distribution itself from first principles. There has been quite a few works on trying to empirically fit distributions based on the available data. What we will be trying in this work is that we will be trying to develop this distribution, this PDF, the probability density functions of such distributions of the secondary cases, of the number of secondary cases created by one index case from first principles, and then try to compare with the available data. The advantage is that this is predictive. This can be predictive if the model is good, and it can enable rapid testing of precision mitigation measures before the event happens itself. So the objectives of this talk is that analytically model the distribution of the secondary infections within indoor spaces, apply the model for school and shelter settings. And why school and shelters? I mean, one reason is that both are two of the most vulnerable cohorts in terms of the outbreaks. And also what the method that we will develop for the schools will show that can be extended to shelters after including some additional complexity. So the basic model that we will develop will be essentially for indoor spaces, which we'll use for schools, and then that will extend to shelters. And then we will compare the model for both school and shelters for two infection periods, alpha and delta. For schools, we'll compare for both alpha and delta. For the shelters, we'll consider only for the alpha. Okay, so this is the first part of the work, analysis of SARS-CoV-2 infections in schools. This work has just been accepted in Proceedings of Royal Society A. It will be published soon. So analytical model in a classroom setting. Let's consider one indoor space. Let's say this red individual, as you see here, is the index case, the infected individual. And that person, by speaking, by coughing, is ejecting virus-laden aerosols. These aerosols mix with the inside the entire room due to air currents, due to several physical processes like there is mean flow of air currents inside the room. There is turbulent diffusion. These processes can essentially be modeled using a partial differential equation, which governs the concentration, the evolution of the concentration of aerosols at each point inside the room. But that's only one part. The second part must be that how does these individuals which are located at different points in the room, if they inhale these virus-laden aerosols, what is the chance of them getting infected? Now, of course, that's a very complex thing because it involves many features like the virulence of the virus, the susceptibility of the individual, the immunity, several things. But I mean, in a pioneering work some time back, Charles Haas proposed this dose response function, but this very complex process can be modeled using this function where P represents the probability of a person getting infected upon inhaling certain number of virus counts. Okay, so this R represents essentially the dose response constant. V dot in is the rate at which you are inhaling the air. This Cj comes from this above equation, which represents the concentration of the virus particles per unit volume of air. And this tau is the time of exposure. So combining these two, one can essentially, in principle, model the probability that a person will get infected in a room which is being shared with an infected individual, or the index case. Now, of course, I mean, as you see, that solving these equations is no easy task. Yeah, if you have to solve this exactly, I mean, you need to have computational fluid dynamics. But if you are trying to obtain a probability distribution, then you need to repeat this process over several hundreds and thousands of cases, which becomes very prohibitively expensive. So what we'll do is that we'll develop certain models for these virus concentrations from available data. And then we will assume certain behavioral patterns based on which we will develop the probability density function of the number of index cases that can be generated inside schools. Okay, so here once again, coming to this dose response model, does account for the fact that these individuals may not be fixed at a particular location, but that can be moving. And what we will do is that we will, instead of solving this, we will try to split this into certain simplifications. Anyways, so this P represents the probability of a one individual person getting infected. To estimate the total number of people that will be infected, we just need to sum over all the individuals that are susceptible individuals that are present inside the room, and which will give us the secondary infection count like this. And these includes all like the behavioral factors, as I said, and that can be simplified assuming that there is a group of people who are being exposed to an average concentration or a long-range concentration of virus particles, whereas there is another group of people who are exposed to the short-range concentrations, very highly dense concentration, which emerges from like one-to-one talking and one-to-one interaction, so on and so forth. So by this way, we can essentially simplify the process to a certain extent, and that allows us to break up this total number of infected individuals into a long-range ZL and this ZS. The people who are infected due to long-range interactions and people who are infected due to short-range infections. Of course, the ZS can include ZL also, but it can be shown that this approximation works in most cases. Anyways, we now need to model the concentration of the virus particles in the room, and that has some degree of heterogeneity itself in it. But it can be once again shown that if the virus concentration is reasonably large, then assuming a mean concentration, and if the heterogeneity is not too strong in this case, like the concentration of virus particles, then it is sufficient to assume that we can replace these functions with a mean, and that simplifies the calculation significantly. So anyways, so this gives us the secondary infection count, whereas now we have this NL is the number of people who are in the long range at a significant distance from the individual, from the infected individual. NS is the number of people who are in the short range, and these functions basically represents the probability of them getting infected. And this mean concentration, as I said, can be shown that it is a function of the viral load, the ejected mucosalivary fluid ejection rate, the A being the sink strength, the things that remove the virus, like ventilation, like settling, so on and so forth, and VL is the classroom volume. Similarly, there can be a mean concentration for the short range concentrations also, which is also a function of viral load. Now, Now the question arises that where does this heterogeneity which we are after, that we want to model the distribution of Z, where does this actually emerge from? I can tell you that this emerges essentially from the distribution of the occupancy, the number of susceptible individuals, the R, the dose response function, and CL, where the heterogeneity of CL itself, or the CL bar itself, arises from the viral load. So we need to know the distributions from them, and they are available from published data. We can find out, there is databases available which models shows the distribution of the viral load, which can be modeled using a log normal distribution. The dose response constant can also be modeled using log normal distributions, and the product of this R and the CL then gives rise to another log normal distributions. And then if you have a model for the distribution of NL, you can show that these two can be, because the Z is essentially the sum of these two, and under the assumption that they're independent, we can show that the net distribution of FZ can be shown to be a convolution of the far field, or the long range FZL, and the near field FZS, and which gives rise to this. Now, so all this is the modeling part. Now we look into the data. Ontario government published the school infection data during COVID, and before doing that, we need to do some analysis on the data so that it is amenable to be compared with our model. So first of all, we assume that the fraction of the index case inside schools is equal to the fraction of index cases inside over the entire population. So that's one assumption. But once you do that, it can be shown that the number of index cases in schools comes to about 1 in every 4 schools, and that enables us to simplify the model significantly by assuming that there is only one person in infected case in the entire schools, and there can be one. It's safe to almost assume that there is one infected case in an entire classroom. So using that, you can simplify the overall modeling of infection spread inside schools to infection spread inside a classroom itself. Anyways, so with those data analysis, let me go to comparison of the model and the actual real world data from the entirety of Ontario public school system. So if you look into the left plot, where we see the alpha variant, on x-axis you have Z. Z is the number of secondary infection. On y-axis you have the probability density function in log scale, and this is the data. We will show you the data, how the distributions look like every 2 weeks. So first, this 8 February 21, 16 February 21, you see that there is a trend emerging, and initially there is some variation probably due to opening of schools and so all those things, but eventually the data settles into a kind of a fixed trend, where you see that this over dispersed and a very strong heterogeneous nature of the distribution of the infected individuals, of the number of secondary infections emerge. And we see that clearly the data shows a very long-tailed behavior, and it peaks around at 0. So once again, this tells you that in schools also there was significant heterogeneity in these distributions, and there was significant superspreading event. Of course, superspreading events are of much lower probability than of the lower number of infection spread. Now, this is the data sets. Now, how does our model look like? If you consider only the long range infections, this is the dashed line shows that. If you consider only the short range infection, the dotted line shows that. Now, if you do the convolution of these two, this is what the model final output is. This full solid black line. As you see, qualitatively the model captures the trend pretty well. Of course, quantitatively it still under predicts the super spreading events to some extent for the alpha variant case at least. If you look into the Delta variant case, we see that this was during September 21. We see that once again the data shows similar trends, but once again we see that after a bi-weekly interval, 2 weeks interval, the data shows converges into one single trend, and once again the similar feature is noted. Of course, Delta was more virulent, and clearly that is evident from the longer, even more over dispersed, even more right-hand side shifted tail of this infection distributions. Okay, and this is where it settles. And as you see here, that this has a very strong heterogeneity, and you have more propensity of super spreading events for the Delta variant as well. Now, if you now see where how our model behaves, this is after including all those distributions for the enhanced viral load, enhanced dose response constant for the Delta variant. This is how a long range prediction works. This is our short range prediction, and then the convolution of the long range and the short range gives you this. And here we see that the model does much better qualitatively as well as quantitatively. It quite well predicts the data sets. Now, I'm not totally sure on the reason of why the alpha variant case is underpredicted. It is possible that when the viral load is very high, when the dose response constant, the propensity, the virulence of the virus is very high, there is the other factors kind of subside, which perhaps contributes to the lesser uncertainty of the model. Could be. I'm not totally sure on that. I mean, we are still trying to figure out this part of the story. Anyways, and the gray lines shows the uncertainty bands that emerges from consideration of the variation of the parameters that we have assumed as constant. Anyways, now if we extend this model to shelters, first of all, there are around 100 shelters in Toronto, and which accommodates 9,000 people. Of course, it houses a very vulnerable population, and it can be hotspots for super spreading events. There can be three kinds of shelters, essentially: single large room, traditional hotels shelters. We will model the traditional ones. And this will consider the traditional ones are more complex because there is a multi-room scenario. I mean, as you saw that in the school system, we could get away with modeling one classroom itself, and we could assume that the individuals are inside that classroom for extended periods of time. Now, this doesn't happen in a shelter environment. There is a constant inflow outflow of people across different rooms, so that needs to be modeled as well, and that brings in further complexity. So we had to include an additional parameter M, where we essentially assume the person being exposed to could be exposed to could be inhaling virions over multiple rooms itself, and that related to some additional modeling and complexity. But overall features of the modeling remain same. And another point is that in the school system, I mean, we could work with a lot of data, and we had converged data reasonably. In this shelter system, though this data is extremely valuable, thanks to Professor Mishra, but as you see, the data is a little bit scattered near the tails, and this calls for modeling the tails itself, which Arnab did, incorporating some extreme value theory from statistics. So what we will be targeting is essentially not only the data, but rather this tail, which is the output of the extreme value theory. So once again, this is the secondary infection count, similar to what we did in schools. And then we need to find an estimate for the occupancy distribution. So now, the first question is that how many people are present in a shelter, and there is data available for that. The second is that not all people may be susceptible, may not be exposed to the index case. So we need to have some additional modeling for that as well, and that we arrived at using the total occupancy, which shows a log normal distributions. And then we, given this number of people, we obtained a modified distribution for the number of susceptible individual, and this includes the effect of vaccination and coverage as well. And there are some, as you see, there are some parameters which emerge, but we do not have data for these parameters. So these are, at this moment, we have assumed certain numbers for these parameters, certain reasonable numbers, but these are very much to some extent ad hoc. So we are still working on them, on whether it's possible to estimate these numbers better. As a result, the shelter work is still a work in progress. Anyways, if we also had some additional modeling to do to estimate the number of individuals who are exposed to short-range interactions. And given the paucity of time, I'll just try to summarize. So this is the result for the shelters. This is the data that is available. As you see, once again, this shows an over dispersed nature where the PDF has a long tail, which shows a small but finite probability of a large number of secondary infections emerging from a single index case. So x-axis is the number of secondary infection, y-axis is the PDF, and this is the data. And we should be targeting to model this dashed line, which is the output of the data using extreme value theory. So if you consider all the individuals that are present in the shelter system to be exposed, this is what the black line shows. This kind of over predicts the model. If you just consider the short range interactions, this is what we see. If you consider the long range interactions, this is what we see, including a model for a reduced number of susceptible individuals. And if you and again, convoluting those two, what we get is the final output is this. This is the solid black line, which is the model for this dash dot line. This, once again, it shows reasonable qualitative and quantitative agreement, and there is some under prediction in the alpha variant case, as we had seen in the case of schools also. So that is one aspect, as well as the trying to figure out those parameters like exposure duration and all those things. Having better estimate for those is the future work, and we are to fine tune the model further. Anyways, so to conclude, what we have developed is an analytical model capable of reproducing the heterogeneity in an airborne disease outbreak. To our knowledge, I mean, while there has been many attempts to empirically fit available distributions, we are not aware of any attempt which has tried to model such distributions analytically. In any case, we developed that, and we compared the results with two real-world scenarios, schools and shelters. So this is the output of the school model comparison with the school data for the alpha variant. This is the output of the shelter model and the comparison of the shelter data of secondary index cases of secondary infections in case of the alpha variant. And what it does essentially is that the analytical nature of the resulting distributions not only allows us to better understand what is going on, but it can allow us to test the effects of various mitigation measures, given that they are sufficiently robust and is really capturing the truth. And the shelter model will be refined and coded such that it can be available for use by policymakers, of course, after further rigorous testing. And with that, I thank you, and we'll be happy to take questions. Thank you so much for giving the opportunity to speak here.
Thank you, Dr. Chaudhuri. So I'm looking at the time. So if anyone has any quick question for Dr. Chaudhuri, please feel free to ask. If not, I will encourage everyone to send encourage audience to send the
Tito, I
questions.
wanted to answer one of the questions because we are very short on time. I wanted to first thank them for the suggestions, and this is exactly the plan that we have. After we have hospitals registered to our system, we're really hoping to be able to involve them in the decision making and letting them know about like the stories that we learned from the data. And also about the second part of the questions, that how can we make sure that troublemakers are not contributing too much to the data? The second paper that I shared during the presentation, called Fair NLP, is designed to make sure that we are debiasing the comments that we receive from the public. But again, we are in very early stages of the deployment of the system, and we definitely will have a long game to play to make sure that the data that we receive is clean, is not biased, and it's actually contributing to the process. But thanks so much. Just wanted to make sure that I answered this question too.
Thank you, Dr. Chaudhuri. So I just wanted to also mention that we will also send the answers via email to everyone with the recording as well. So we'll go into wrap up now. So thank you everyone for attending, and thank you especially to the presenters for taking the time. So if anyone has any other questions, as I mentioned earlier, feel free to reach out to the panelists directly. I want to highlight that this is an ongoing series. So our next session is going to be on January 13th. The topic on that one is more on supporting vulnerable populations. We will have Andrew Pinto of St. Michael's Hospital, and Sean Morris from the Hospital for Sick Children presenting. Feel free to use the QR code to scan and register, or you can also go to our website, pandemics.utoronto.ca, to register. And you can also register for any of our subsequent months as well. Thank you everyone for attending today. Thank you again to the presenters. We will get the recordings and slide to everyone who has registered, and look forward to the January session.
Thank you very much. Bye-bye.
Really appreciate your time.